disclosures. Manny wanted me to disclose all my disclosures. This is a list of my disclosures, but I have one other conflict of interest. Actually, I had dinner with Manny the other night, and that is a severe conflict of interest. So moving on, it's important to realize that the hemodynamic derangements of sepsis. Sepsis is a vasoplegic state characterized by vasodilatory shock and venodilation, leaky capillaries, myocardial depression, and diastolic dysfunction. Sepsis is primarily not a volume-depleted state. I think this is such a really important concept. Patients have not lost fluid. Patients have severe venodilation. They have a large increase in their unstressed volume. If you give fluid, as illustrated in this cartoon, all you do is increase the unstressed volume. And in fact, fluid in the setting of sepsis is a vasodilator. Sepsis, in the setting of sepsis, fluid can be a vasodilator. And that was elegantly demonstrated in this study. And I quote the conclusion: fluid administration significantly reduced arterial load in critically ill patients with septic shock and acute circulatory failure, even when increasing cardiac output. This explains why some septic shock patients increase their cardiac output after fluid administration without improvement in blood pressure. Fluid is not a vasopressor agent. To the contrary, it causes vasodilation. So the hemodynamic derangements of sepsis: fluids increase vasoplegic shock, fluids increase leaky capillaries, fluids increase myocardial depression, fluids increase diastolic dysfunction, fluids increase mortality. That's just the way it is. Sepsis is not a volume-depleted state. As illustrated in this cartoon, what happens is you have profound venodilation, particularly in your splanchnic bed and your skin. This decreases venous return because of your increased unstressed volume. If you give a venoconstrictor, you restore venous return and cardiac output. And this is not fluid which leaks out. This is blood which stays intravascular. So what are the goals of hemodynamic support? I think we all agree you want the MAP above 65. You don't want a tachycardia. And then you want adequate tissue perfusion. And contrary to what surviving sepsis tells you, you want the CVP to be less than 8. A CVP above 8 is associated with increased risk of kidney failure and death. So this is probably the best study which illustrates this point by, I think, probably the leading experts in this field, Dr. Monet and Tabul. So what did they do? Early administration of norepinephrine increases cardiac preload. So this is a concept people don't really often get. You're giving an alpha agonist to venoconstrict, to increase venous return, to increase cardiac output. So that's exactly what they demonstrated. So you can see with norepinephrine, MAP goes up, cardiac index goes up, global end diastolic volume and an index of preload goes up. So you're giving an alpha agonist, which increases venous return, increases cardiac output, and increases blood pressure. And indeed, the data shows that the longer you wait to give norepinephrine, much like antibiotics, we know that the delay in antibiotics improves mortality. Early versus delayed administration of norepinephrine in patients with septic shock shows you this very nice little forest plot. The longer you wait, the worse the outcome. So this idea of giving large volumes of fluid which vasodilate and make the patient worse, and you keep on following this ridiculous cycle until you've drowned the patient, and then you add norepinephrine, you can see why this leads to a really bad outcome. One of the points people would say, well, I can't start norepinephrine in the emergency department. That is wrong. you can give norepinephrine safely through a peripheral intravenous line. You can start this in the emergency department. And I will show you some tricks that allow you to get them off norepinephrine within 24 hours, and you never need to put in a central line. So, which pressor? A, B, C. So this is a meta-analysis done by DeBacker looking at norepinephrine versus dopamine. Clearly, norepinephrine is the vasopressor of choice. Well, what about vasopressin? So this is the VAS study in which there was no mortality benefit from vasopressin. We then go to the VANISH study. Again, no survival benefit with adding vasopressin. One has to be careful with vasopressin. If you look at the VAS study, the VANISH study, and every other study that's used vasopressin, vasopressin causes microcirculatory dysfunction and increases the risk of ischemic skin lesions and peripheral gangrene. So those are two real patients. The one on your right was a lady who was 18 years old, presented with septic shock. They waited 18 hours to give antibiotics. They waited 24 hours to give a vasopressor, and they gave her vasopressin. She lost both her arms and both her legs. So this is the new play on the horizon, and people are all so excited about vasopressin. So you can see it is a vasopressor agent, and it increases blood pressure. But does it change outcome? You can see the change in SOFA score, angiotensin II versus placebo, exactly the same. Exactly the same, and the SOFA score went up. Okay, you want the SOFA score to go down. And I'll show you an intervention which makes the SOFA score go down. There was no change in mortality. What they don't tell us is how much this drug is going to cost, and I'm sure this is not going to be a cheap drug. So we know what pressor we're going to use. We're going to start off with norepinephrine. What's the target? So you're all aware of the study, which was an outstanding study, selected two targets, 65 to 70 to 80 to 85. That caused a nice separation in blood pressure with no difference in outcome. Now, one could argue about fine-tuning, but for the doctor, the average doctor treating the average patient, whatever the average patient is, you want to target a MAP of 65. So I think we can say that pretty confidently. We spoke yesterday about broad implications of treatment of sepsis. The first thing you can apply to any patient anywhere in the world, or in fact on any other planet, is get the MAP above 65 with norepinephrine. So we come to the next piece of this really exciting puzzle. So we published this paper in Chest, hydrocortisone, vitamin C, and thiamine for the treatment of severe sepsis and septic shock. We published it. The results were interesting. Many people were excited. Almost exclusively, all the sepsis experts in the world think this is the biggest lot of BS they've seen. Anyway, the most interesting thing about the study, which is reproducible time, over time, over time, over time, is within 2 hours of starting this cocktail, the patient's doses of norepinephrine go down. This is absolutely reproducible. It's as reproducible as gravity. And the mean duration of vasopressor therapy in patients in severe vasodilatory septic shock was 18 hours. We have not had a patient who has had refractory septic shock that was unresponsive to this regimen. We have not seen such a thing. So if you look at the literature, what is the average duration of vasopressor dependency? So you can look at the Corticus study, control group 139 hours, treatment group 79. Dr. Fowler's vitamin C study, 93 versus 50. Dr. Zabet, who did a study in abdominal sepsis in patients with septic shock, 70 versus 48 hours. Our study using the combination of steroids and vitamin C, the control group 54, as I said, the treatment group 18 hours. So pressors should be used as salvage therapy to get the blood pressure up. Clearly, the longer the patients are on vasopressors, the more organ injury and the worse the outcome. And the remarkable thing is, you get them off the vasopressors, and when they're off vasopressors, they are not suffering from salt water drowning because you have not drowned them with fluid. You have not given them 30 cc's per kilogram. You have not flooded them with fluid, and fluid does not increase your blood pressure. That is a fantasy. So if you look at the SOFA score in our patients, compare this to angiotensin II, the SOFA score in the treatment patients went one direction and one direction only, and that was down. The mortality, which is, people say, it's impossible. How could this be? Why should I lie? This was the mortality. Profound decrease in mortality. So just to add to the scientific data, this is a study just published in Chest in which we tested this combination in vitro in a laboratory where you can control for every event. So you can't change proteomic or gene expression. You can't do that. And we showed conclusively that this combination protects the endothelium against endotoxin. So I have 3 minutes over, so I'm just going to present to you that the treatment of vasodilatory shock is 1, minimal fluid. Fluids do not increase vasomotor tone. 2, norepinephrine. 3, you start this cocktail as soon as you can. This will get you off your vasopressor agents, and your patient will leave the ICU in 3 days with a big smile on their face and no residual organ failure. Our hospital administrator is really happy because our length of stay for septic shock in the ICU is 3 days. Our patients do not get, the risk of renal failure is significantly less. We have amongst the best, the lowest mortality for septic shock in the United States, despite the fact that we are only 11% compliant with the SEP guideline. So there you go. I think the evidence is in the pudding. Thank you.